Hello, everyone. My name is Bipasha, she, they pronouns, serving on CRIS as person with lived experience. I was going to be there in person, but last minute issues prevented that. Kristen, you're on mute.
There we go. Now I'm off mute. Hello, I'm Kristen Wells, she and her pronouns, and I'm also one of the lived experience representatives on the CRIS. I see that the slides for our presentation aren't up yet, so there we go. We're excited to share with you some of the insights that arose as we read the stories from the Lived Experience Stories project over the last few months. Both Bipasha and I realized how much of what we heard this morning in the DD and IDD panel is echoed in our findings, so we really hope we can address all those overlaps in our discussion. Next slide, please.
Okay, first a little background. For the last 3 years, we've heard from folks with lived experience at our monthly Monday afternoon meetings and from those who are able to share their stories directly with us at the CRIS. But we know that not everyone can participate on a Monday afternoon. So our hope with this project was to cast a wider net and hear from folks, especially those from more marginalized communities. We collected stories through June and July. It's a small sample of people who were able to submit. It's not a representative sample. We had 65 valid stories that were coded, and insights about different parts of the Washington behavioral health crisis response system were drawn from these stories. Next slide, please.
These are the demographics that we captured during the project. Please refer to the detailed demographic slides in the appendix for information about each of these demographics. There's a few things we'd like to highlight about the demographics before we get started, though. In our lived experience subcommittee meetings, we've not heard much from folks who had substance use disorder, housing insecurity issues, or involvement with the criminal justice system. We're happy to report that we did capture stories from each of these populations in the Stories Project. Unfortunately, despite our outreach efforts, we received very few first-person stories from young people, though we did receive some second-party stories that involved youth. Most submissions involved people who accessed the behavioral health crisis system within the past 2 years. Next slide, please.
Okay, as we move forward through the presentation, please note that for every insight, you'll see bubbles that are verbatim quotes from the stories submitted. Any words in square brackets are clarifications we made to the quotes. All acronyms are at a slide in the end in the appendix if you want to look at it. And for the presentation, we did whittle down the quotes that we're using. This is an important note, the next one. We have left the names of agencies and services that were in the original quotes. This is to honor the lived experience voice as they were shared. We have precedent for this, as you well know, that at the CRIS meetings, when we had people share their stories, we didn't tell them you cannot name an agency if they wanted to do that. So we're following the same guideline. It is not our intention to demonize or angelize any agency. We're trying to really honor the lived experience voice. We're aware that most agencies do good work. One incident or story does not determine the overall quality of care agencies provide, but the stories we're going to hear from can help us build a stronger, better system. So we're going to start with things that are working well in our current behavioral health crisis system. Next slide, please.
From these quotes, we can see that people are receiving help across the continuum and beyond. First quote, "My friend OD'd. I called 911, needed urgent medical advice. Immediately, paramedics arrived and had some drugs to counter the overdose, and my friend got stable." Second quote, "DCR was professional, kind, and caring. DCR even called every hour until the agency opened up." Third quote, "I was diagnosed by my primary care doctor with life-threatening liver, kidney, and pancreatitis disease due to my alcoholism. When I got totally honest with my primary care doctor and my therapist, I was referred to a detox and inpatient treatment." And final quote, "I called 988 and gave them all the information I had. 2 people from Mobile Crisis showed up, male and female, in less than an hour. That was impressive." In addition to those quotes, we heard about a group home that was excellently run, PACT being very impactful, pun intended. A shout out to HCA for helping a client who was stuck with accessing services, and ED social workers who were kind and connecting people to ongoing resources. Next slide, please.
Okay, so now we'll move through insights from stories about things that didn't go so well for folks in their experience with the behavioral health system. Next slide, please.
Although there's a lot we could extract from these stories, these are the 7 big insights that resonated most deeply for us. As we go through each insight, we'll zoom in on some details and sub-insights that stood out. Next slide, please.
So our first insight is that the criminal justice system and emergency departments are functioning as primary access points to behavioral health care and the crisis system. There are 4 nuanced insights under criminal justice system before we get to the ED insight. Next slide, please.
Our first sub-insight is that stories involving the criminal justice system are showing that people are ending up in criminal justice during a crisis rather than receiving immediate behavioral health support. Quote, had there been easier access to a program like drug court, I could have avoided the multiple felonies I have on my record and had a supportive program behind me. Next slide, please.
This next sub-insight from the stories was that the criminal justice system is often traumatizing for people who enter it, which leads to or exacerbates behavioral health crisis issues. Quote, my first stay in prison was devastating to my psyche. I found myself in a world of which I knew nothing about. The fear and depression was contagious. It permeated every single day of my life, which I believe became the catalyst for the subsequent drug abuse and mental health problems. Next slide, please.
The next sub-insight is that while it's not preferred route to behavioral health support, some people are accessing helpful programs through the criminal justice system, which is better than not getting any behavioral health care at all. Ideally, people should know how to get behavioral health care early so their lives don't intersect with the criminal justice system. This is better for the person, their loved ones, and the community. Quote, while incarcerated, I was introduced to the Change program through Progress House Association. It was this program that ultimately helped me change the trajectory of my life. Knowing that there are programs, resources, housing, and hope helped me change my life. I'm very eager and excited about the opportunity of a new life. It is my goal to tell others that they can make it just as I did. In addition to this program, we also heard of the Houses of Healing program that was very helpful to someone else. Next slide, please.
Our final criminal justice sub-insight is that when people are re-entering their communities after incarceration, the transitions from criminal justice-based behavioral services to community-based behavioral health services are rather difficult. Quote, I was incarcerated for 7 years and took medication and saw a psychiatrist. Washington State Medicare would not accept documentation from Washington Correction Center for Women. The psychiatrist outside tried to prescribe me an antipsychotic that was not available at WCCW. I went down to Kaiser to get the medication, and Molina Healthcare and Washington State Healthcare would not give me the medication. 9 months into the process, I did everything I was supposed to do, and I was not given the medication that would have prevented a relapse. Next slide, please.
We've already had some conversation in the CRIS about emergency departments as non-ideal access points to the behavioral health crisis system. We hope that the 23-hour crisis centers will be a valuable alternative, but we still wanted to share some quotes from some stories about the difficulty of accessing adequate behavioral health care when presenting at emergency departments. Quote, they eventually called me back, took all of my clothes and possessions, put me on a stretcher in the hallway, and proceeded to leave me alone there with no sedatives or anything in the middle of the ED chaos while feeling suicidal. We know that long ED times are hard, period. But when you're in a behavioral health crisis, those long wait times can make things worse for people. Second quote, the student was held in the ER for about an hour. Then the actively suicidal child was discharged to the street. with no notification to their parent, no safety plan, no care plan, no follow-up scheduled, and certainly no admission to inpatient. Next slide, please.
This is the first suggestion section. Suggestions throughout the presentation are based on what we read in these stories, but these suggestions are also reinforced in our lived experience subcommittee meetings over the last few years. Quote, a DCR was with the police and offered my son a mental health evaluation. My son declined. The DCR told me the arrest warrant for missing a hearing superseded her mental health evaluation. We're suggesting that we allow behavioral health intervention to take precedence over criminal justice, especially when there is an arrest warrant for non-violent crimes. Next slide, please.
Our second main insight is that there are multiple barriers to accessing behavioral health services before, during, and after a crisis. The CRIS has talked about some of them already, but some of them are new. Next slide, please.
This slide covers barriers related to insurance, cost of care, and transportation. First quote, my daughter has received a bill for $5,500 from Capital Medical Center ED. Next quote, I can't drive a violent kid nor drive in night nor safely transport. So in addition to quotes about transportation and getting bills, people talked about really a hard time finding providers who accept Medicare, Medicaid, and how out-of-pocket care is too expensive. Next slide, please.
The next sub-insight from these stories was a serious lack of resources, posing a huge challenge to accessing behavioral health services. First quote, no other teams or services for our remote area in Goldbar. Second quote, I wish we had drop-in centers or clinics where people could access mental health counselors to talk to. Third quote, in the year prior to him going into the CLIP facility, he spent probably almost 40 days sitting in Sacred Heart in their emergency room. People also talked about a lack of medication providers, detox beds, counselors, especially those with specialized skills like trauma counseling, and youth counselors. All of this leads to long wait times. There's a lack of one-on-one counseling in inpatient units, and there are staff shortages leading to poor patient experience. Some of these quotes resonated with what we heard from the rural and agricultural panel, the youth panel, and also much of what we heard today in our panel before lunch. Next slide, please.
Our third insight is that existing protocols are unaligned, inconsistent, confusing, and often do not meet the needs of the community. Protocols exist for a reason and might cover most people, but when they fail, it can have a very negative impact on the person and the community. Next slide, please.
Here are some examples of protocol hitches across the system. First quote, 911 literally would not come even when he was trying to kill me and himself because they were legally not allowed to restrain minors. Second quote, in the state of Washington, the only medications that can be legally compelled are antipsychotics. Mood stabilizers cannot. This is a real problem for someone who needs mood stabilizers to stay stable. Third quote, a nurse drew blood, not telling me why, and I was shocked to get the notification through my chart that they had done a tox screen looking for substance use. One thing that I know as a social worker in the system is that emergency departments run labs to rule out alternative causes for what appear to be mental health symptoms. For instance, psychosis caused by substance use or a medical condition, such as a UTI. They're doing these tests with the intention of getting the right care for patients, but if no one takes the time to explain that to a patient, it can be very upsetting. Fourth quote, I ran out of medication, had seizures for several months, almost died because nobody titrated me off any medication. Nobody had any ability to get me my medication again. When people change providers, they often need to meet with their new provider first and complete additional requirements before they will continue a prescription from a previous provider. People cannot always meet these requirements fast enough and may run out of medication during that transition, which can be a precursor to a crisis. Next slide, please.
These quotes speak specifically to challenges around DCRs and the ITA protocols. First quote, officer called me back, letting me know my son didn't qualify for an IT under Ricky's law since he hadn't physically assaulted anyone in our home or committed a crime. Next quote. I was thinking he, crisis center social worker, would start the ITA process. He parked outside our house and then left without letting us know why. I called the crisis line back and I was told he felt unsafe going by himself, so he contacted Skagit County Sheriff's Office, asking them to come to the house. Next slide, please.
Here's our next set of suggestions. First, we need to educate the community about what each part of the system does and be transparent on what they can really expect. First quote, we ended up calling the police because we didn't know what else to do. This quote indicates we need to continue increasing awareness of 988. Second quote, crisis lines are 50-50. Often you just run out of time before you're de-escalated and feel abandoned when they hang up on you. This quote indicates that in addition to learning about 988, we need to educate people about what 988 does and what it is not. The community could be educated about the difference between crisis support and therapy, and that 988 does not have therapists for full sessions. Next slide, please.
Continuing our suggestions, standardize education for all service providers on how the system works in their domain and other related relevant domains. Let's consider this quote. Improve the ITA requirements gearing more towards prevention rather than someone having to commit a crime in order to be ITA'd. Our suggestion is to consider changing or improving protocols to better support the community. How effective are the ITA protocols in supporting the community as they are currently written? We really need to delve into this. Next slide, please.
The fourth insight is that the quality of support people receive across the continuum is inconsistent at best. Under this insight, we're highlighting both positive and negative experiences people had under each pillar. The proportion of positive versus negative experiences captures our sense of the ratio we saw across our stories. Again, this is not a representative sample. Next slide, please.
So for the someone to call pillar, it seems like a lot more folks are finding regional crisis lines or 988 helpful. This made us feel that the work being done on 988 call hubs is taking shape and going in a good direction. First quote, just talking to someone at a regional crisis line because I was very isolated and alone really helped a lot. Next quote, he, the crisis counselor, did tell me about Ricky's law, which we both felt was the best option. As we can see, it really helps when crisis counselors know the different programs and options across the system so they can better guide the caller. Right now, the knowledge is fragmented, it's not standardized, so the guidance will depend on how well the people on that shift know the system. It really needs to be standardized. Next quote. When I contacted 988 and they contacted the EMTs and police responded to my house. I'm very frightened by law enforcement and first responders. I asked them to please leave my house. One officer stepped aside and told me that they were also a veteran and wanted to help me. I did reach out after and spoke with them. Now, although this story ended with the caller making a positive connection to the responding officer, the caller should have been told what was going to happen. This quote also highlights the vital importance of educating first responders on how to interact with people in behavioral health crises. Additionally, we see that when the provider is able to disclose a shared identity, it can improve outcomes. And it supports the idea of diversity in workforce and peer involvement across the system. Next slide, please.
In the someone to come pillar, the ratio felt about 50-50 with regards to people's experience. Mostly, it felt when mobile crisis responded, people found it very helpful. The bigger issue was when they did not respond. First quote, they, mobile crisis, spent a long time listening to his story, and in the end, they gave him advice, which was to go voluntarily or be ITA'd. These two professionals were the best part of all the services. Second quote, I wish that the mobile crisis team had been more responsive to us and had actually come out to see her. Next slide, please.
This pillar of somewhere safe to go or be had the longest list of negative experiences. This area needs a lot of work to earn the trust of the community and encourage people to get the help they need. This is the pillar that will likely also take the most time. Quote, I would have never guessed that being diagnosed with schizophrenia and going to transitional resource would give me a future and save my life. Getting a diagnosis felt like a restart. Next quote. Inpatient was horrific caged animal experience. They threatened him with being sent to Easton in a straitjacket and told him he'd get ECT. Third quote. When she finally came home from inpatient, she said they did not help her in any way and she will never ask for help again, as she felt she was in jail there. That last quote, it's important to see how one awful experience can change a person's relationship with treatment in devastating, sometimes even fatal ways. Next slide, please.
Our next insight is that bias may be playing a role people are getting. First quote, the system also ignored my suicidality because I am in a wheelchair. My problems were minimized and ignored because I am in a wheelchair. My PTSD was being aggravated but ignored because I am in a wheelchair. I was not hospitalized because I am in a wheelchair and unable to take care of myself and meet my ADL.
Next quote. They dismiss her because of her race or apparent drug use. She needed more workers familiar with trafficking. I wanted to let you all know that this person in the story died due to an overdose on the street. I cried when I read this story.
In addition, we heard about people being misgendered, treated poorly for being homeless or speaking with an accent, and about single fathers having fewer resources than single moms. Next slide, please.
So this quote captures the positive experience of good staffing. Harborview has the most doctors, beds, and because they pay the best, some of the best staff. Here are some of our suggestions on helping improve the quality of support people experience. Adequate pay and personal time off for the staff. Agencies be adequately staffed to minimize burnout. Training for staff on secondary trauma, on unconscious bias, on special needs, minority, underserved population care, on trauma-informed care, and most important, enable system users to rate the quality of care. Next slide, please.
Our fifth insight is that there are many gaps in collaboration between parts of the system and across systems. Next slide, please.
This sub-insight is that follow-up is not provided or adequate, and if they are told there will be follow-up, it doesn't come through. Quote, in the end, the youth was discharged with the PRN and no way to move forward or anyone to check in on him, his family in the following days, as it was a weekend. Next quote. 988 told me to call 911, which was a loop of numbers, having to answer questions, never getting anywhere, ending with asking if I want to answer a 4-question survey. Next slide, please.
The various parts of the system do not talk well to each other and people are falling through the cracks. Quote, with regards to gaps between services, there needs to be a service between WISE and CLIP. When WISE isn't enough, but the ER nor 911 are appropriate, where can a family get help?
So I think I said 911 in the previous slide. It's 211. I apologize. This next quote I can echo, having heard it from clients on the crisis line for 27 years. I don't know if the community providers we were working with just dropped the ball or if they didn't know either. And it seemed to us like everywhere we went, there was just kind of like this confusion on what the information was. Or the answer we got, oh, I'm not sure about resources. I have to check with this person. Then I'm going to have to double check with this other person. And it was always like a ball being passed from one person to the next until finally we had kind of reached a point where we had been struggling for so long. Next slide, please. Some suggestions from us. Let's start with the quote. Basically, I feel like there is support available, but it's too spread out between a million different organizations, and navigating this is a difficult process. A suggestion is, if 988, someone to call Pillar, is going to be the hub, we really need to educate the crisis counselors and staff to know the system in depth, or at least be able to find the required standardized information in a centralized location, maybe on the 988 tech platform. Without this, forget the gaps in the system. Even parts of the system that are available are not accessible. Next slide, please.
Our sixth insight is that follow-up and prevention must be added as a pillar in our system. We need to blur the lines between crisis, postvention, and prevention. To think of one without the other is a disservice to the whole human. Next slide, please.
This sub-insight is that without follow-up and prevention measures in place, people keep cycling in and out of behavioral health crisis response. Quote, where are the peer support counselors? Where are the people that link my ability to stay stable and well? Next quote. Ensuring seamless transition to ongoing care and support beyond the initial crisis. I hope they integrate substance use crisis response with long-term recovery resources. Third quote, after 3 months at a long-term facility, Teleka in Shelton, he was released to a homeless shelter in the University District. He was arrested 6 hours later after smoking something, taking off all his clothes and dancing in the street nude. It was clear he was not stable when he was released, even though he was at this place for 3 months. This is utterly stupid. Releasing someone as mentally ill as my son to a homeless shelter in the University District is negligent care. Next slide, please.
Additionally, the lack of basic needs being met can trigger behavioral health crises. First quote, housing was another issue though, and while everyone else seemed to get free housing after a time, I could never figure out how. The issue was that they were always reward-based or contingent on sobriety, completion of a drug treatment. You could get something like housing, but you had to be clean and stay that way. There were too many hoops to jump through for basic necessities, so eventually I gave up trying. I was on the streets of Seattle battling drug addiction and homelessness. Second quote, it is common for the closest family members to cut off all contact and withhold any money or direct support once there's a serious crisis. What follows are years of difficulty getting health care, dental care, food assistance from the state, etc. If we want the crisis response system to work well, we must focus on the prevention system too. Going through repeated cycles of crisis is not good for people, their loved ones, or the community. We think it is also a more expensive way to fund the system, just like having a heart attack and requiring medical care or surgery is more expensive than education and support around heart health. Next slide, please.
Our seventh and last overall insight is that natural supports are an untapped resource and need to be an integral part of the design and delivery of crisis response. Natural supports are defined as the unpaid relationships and associations people have in their everyday lives that improve their quality of life. Next slide, please.
There is a need to strike a balance between personal agency and family engagement. We had families say, quote, another weakness is that there is little family involvement with a treatment plan. But families also reported, quote, Harborview, someone on John's team called me and asked for his history and the circumstances of this particular hospitalization. Almost no other mental health facility does this. Sometimes I wait over a week or two before the social worker calls me. Families also touched on the issue of anosognosia, which is a term for when someone is not aware that they have a mental health condition. Quote, she would go to treatment, do better, get out, and relapse. That was a repeated cycle. She was clearly not able to make informed decisions. She continued to check herself out of rehab every time we got her into a substance use or mental health facility. If we had a way to make her stay in treatment until she was stabilized on medication and in the right frame of mind, I feel like this could have prevented. On the other side of this, though, we have quotes from people talking about how their family can be a source of stress or even trauma. Fourth quote, I have had to overcome serious trauma from childhood situations and instances. When natural supports are positive, they can be very beneficial to the person dealing with the behavioral health issues, and as such need to be part of the treatment plan. But we need to recognize that people calling themselves a natural support could also be a source of stress or trauma. This balance or tension between what the family wants and what the individual in crisis wants is something we haven't really delved into in the CRIS, but it's a theme that has come up consistently over the past 3 years in the lived experience subcommittee meetings and in the story project. Finding the right balance will need serious engagement and discussion. Next slide, please.
So people who support people in crisis themselves struggle or can also be in crisis and need support. Here are two quotes. Quote, when there is physical violence beyond the ability of a parent to handle, who can physically come? Literally, no one could help during attacks. He had the legal right to kill me. I'm disabled and lived alone with him. Restraining him requires 3 people. He broke down doors to attack me. I had no safe place. Next quote. And this was submitted by a person calling for help for their ex. I would have benefited from mental health and support systems for myself in managing my codependency and trauma. I could have used some support to get connected with CODA, peer support groups, a counselor, information on codependency, and how to handle situations of emotional abuse. Next slide, please.
Borrowing a quote from Reverend Martin Luther King Jr., here's a verbatim dream from a mom on ideal care for her son and family. Next slide, please.
I want a place for my son that doesn't exist, but if it did, it would have doctors who listen, not over-medicate. It would have treatments like individual therapy. It would have a nice room with soundproofing so he would not be bothered by screaming of others. It would have wonderful, healthy brain healing food, not the cheapest slop. He would have access to the outside. It would provide a step-like system that he would gradually be reintroduced to the real world, like a single room in a locked ward, to a room in an unlocked ward at night, to a studio apartment with medication management. This mythical place would be close enough so his family could visit, and he could do things he wants, like re-enter community college. Always get goosebumps when I read that. Next slide, please.
Please know to each of you who have supported this Stories project, we offer our heartfelt gratitude. Next slide, please.
Yay, we made it. Thanks for listening to us. Here is a summary of our overall insights. We'd love to hear what you thought, what stuck with you, what you felt, any ideas you have to share with all of us, just as a CRIS discussion. And Michael Anderson, AP, who is there in person from HMA, who read the scripts and coded them with us, will join us for this segment. Thank you.
Tremendous work. I only got a small window into how much they were working. They were working so hard to pull this together for all of you. So really big thank you to Kristen and Good Masha for all of your work. And now I think it's time to dive into your questions, Kristen. This is a time for you to ask questions if you have any clarifying questions or if you have any reflections on what you just heard. And maybe to see your thinking, I'm curious if anything you heard today surprised you. I mean, I certainly heard a lot of consistency with what we've been talking about over the last 3 years. I'm curious if anything stood out as new information or surprised anyone. Let me check and see if we have any hands up. Any questions or reflections? Amber.
Thanks. Well, let me start by saying, yes, you got a big round of applause here, and thank you for all the work that you put in putting this together. It really was amazing and informative. I had a question. When you were looking, one of the pieces you talked about, I think it was under quality of support, it talked about safe place to go. And I heard you all that that's one of those spaces that had pretty significant negative comments. But I was curious did you see anything across those answers in terms of where people went in terms of a safe place to go, making any difference in terms of positive or negative experience, or was it more about general access compared to not having access? I was just curious if there was any breakdown in that topic.
Definitely. We, for a safe place to go or be, we got responses about emergency departments, inpatient facilities, and a few about crisis diversion services. We did have some positive quotes for most of them, but in all cases, overwhelmingly, the quotes about a safe place to be or a safe place to go were the most negative across everything we read. It sounds like people are having a very challenging time in general, figuring out where to go to have a positive experience in a crisis.
I mean, and also I just wanted to say that we can, you know, these stories have been submitted. We can always go back with the resources and recode to see what specifically people mentioned so that we get a better, more fleshed out picture of what's happening under that pillar. Just a thought.
I have a hand up on Zoom from Senator Dingrad. Senator Dingrad?
Thank you so much. I actually have no words to express how amazing your guys' presentation was. I love the way it was structured. I liked how concrete it was. I love the recommendations. It's a little overwhelming, to tell you the truth. But I had a couple of questions, and this is not necessarily for the lived experience committee. You can answer it, but even for the other partners that I hear, there's a couple of things that stood out to me when you talked about insurance being a barrier, and I would really like to understand more. Is it having the lack of insurance, or was it the type of insurance? Because a lot of the work that we've been trying to do is around making sure that there is parity in insurance coverage, that they cover mental health just the way they cover physical health. And I think we have the right people in the room to maybe have that discussion on what else do we need to do in order to make sure that insurance does the coverage that's needed, assuming it is a type of insurance and not just they don't have any insurance. And then just a connected one to that was also the filling of the prescriptions. We have done, well, I guess IPRIME sponsored a couple of bills that really is trying to remove those barriers and making sure that the medications that doctors prescribe are the ones that are covered. And so I would love to hear more to see what's going on with our insurance or with healthcare. I don't know if we had a delay on that implementation. The other thing we had done, and I think this may apply only to jails and not our prisons, and so we should have a conversations about prisons, but our jails are now required to fulfill mental health prescriptions in the manner they're prescribed and not do substitutes. And I wonder if we need to do something like that for our prisons as well, because it is always a concern when mental health prescriptions aren't covered specifically as prescribed. And I do believe that bill that I had a couple of years ago did require our prisons to cover them and make sure that Medicare, that our government programs don't substitute other meds when it's related to a severe mental health issue. And I have a couple other questions, but I want to stop at the healthcare prescribed medication and see if anyone else has any comments on that.
I just asked for the demographic slide with insurance to be put up in chat. So we'll see if we can get that one up. I know from memory that most of the people who responded did have insurance. So based on that, my suspicion is going to be that it's about the type of insurance and how many providers are available under that type of insurance. Okay, we've got it up here. So only 5% of people who responded are uninsured. We had 39% with Medicaid, 37% with private insurance, and 19% with Medicare. So that suggests that the problem is about how insurance is covering things, not about a lack of access to insurance. The questions about medication, I can't remember the I don't believe the person from that story specifically mentioned what medication they're on, but I do know that for some medications that are controlled substances, there can be a lot of extra requirements. At the agency I work at, I know, for instance, that to get a prescription for ADHD, those controlled substances often require multiple drug tests, multiple weeks in a row to show that the symptoms they're experiencing aren't based on substances. And as many people with ADHD might be able to tell you, remembering to do that multiple weeks in a row when you don't have your medication might be very difficult.
It's humanizing.
But was just like dehumanizing also.
Yes. It can be very hard for people that say, like, I've been on this medication my whole life, and to be told that, well, we have to do our own checks to make sure that you should be on it. It's very challenging. And let me see if I can remember, what was the third question? Oh, the jail system. That one was you, Bipasha. That's your story, so I'll let you talk.
I just also wanted to say, and Kristen and Michael, please check me. I think the Medicaid and Medicare were the most names that came up in our stories, not so much named. But I do want to say, yesterday I read an article on NPR about ghost systems in private insurance, where people are seeking insurance. It looks like they have a lot of coverage for mental health, but when they start calling the people, they don't hear back because insurance companies are not cleaning out the list of providers they have as a way of inflating the image that they have more providers than they have. And I'll be happy to share the link to that particular article that I read, and so if Jamie wants to share that. I think in terms of the criminal justice system, the couple stories that I read were, I think it was not so much the jails, but the prisons. And I think we tried to capture a piece, but it felt there were stories about people who went back and forth. So they came out and then they didn't get the help. They tried to call, then they went back. So it's this, when they're in the criminal justice system, the medication management and all that is different, and it's not very even. So what they're getting inside, and I didn't know this, but I didn't realize that there were certain classes of drugs that DOC will not prescribe. So when they come out, they're not used to that. So now they have to figure that out. And then in that quote, we mentioned Medicaid, I think, where Medicaid would not meet the antipsychotic that was prescribed. So yeah, that's what Michael, if you remember anything more, you read all the stories too, please add.
Michael doesn't have anything to add. He's shaking his head. He doesn't really have anything to add. I think Dr. Snowden might be able to jump in. Dr. Snowden?
Thanks. I wanted to second what Senator Davis said about how beautiful the presentation was. You guys did a wonderful job. To your question, the part I can add about the medications is for certain newer medications, particularly long-acting antipsychotics, it's not that it's not going to be covered, but it requires a repeat authorization. So you can get it authorized in the hospital, but when that same patient is transitioning to outpatient, the outpatient providers also have to now reapply for authorization. And that process can take weeks, meaning that there's a significant risk that the person is going to run out of the medications that were provided at discharge from the hospital before the outpatient provider has received the authorization to continue the medication.
Can I actually ask a clarifying question? Because I think the bill that I did 2 years ago, the whole intent was that you don't have to get authorization for severe mental illness prescriptions once they have been prescribed. Why would that bill ever?
Okay, it looks like James gonna be able to help us with that one.
I'm just so glad Jane is here. That's all I want to say to everyone. Because I feel all my questions were directed towards Jane, but I didn't want to call her out, but I will now.
That's cool. That's totally fine. So Senator, 5300 goes into effect January 1, 2025. And I can say that one of the questions that's come up from the health insurers is, how do they know that a drug's been prescribed for an SMI because serious mental illness, because of how much off-label prescribing there is? So they're putting they should be putting their heads to how they're gonna review those prescriptions. But it does come to effect January 1, 2025. We're doing rulemaking on it right now. And we always say that if folks encounter challenges and their plan is trying to switch them to another drug, then we need to know and call us with a complaint. The issue that comes up is most of the health insurers contract with pharmacy benefit managers to manage their prescription drug benefits, and those formularies change too often. And your bill is right? We need to keep people stable on meds that are working. So that's that. I listened to the ProPublica story in Pasha also on ghost networks. Ghost networks, Congress has done hearings about ghost networks for Medicare Advantage plans. We have really extensive network adequacy requirements, and the issue that comes up is not only the accuracy of an insurer's provider directory, but also the fact that an insurer can get a bunch of contracts with providers, but there's nothing that obligates the provider to see every enrollee for that health plan. It would probably be physically impossible for them to do that because they wouldn't have room in their practice. So it is an issue of, I think, looking at things like prior authorization, looking at things like credentialing, looking at things like the amount that behavioral health providers are paid for professional services, to try to figure out how we can have, especially the private therapists who are out there, number one, more willing to contract with health plans, and number two, when they do have a contract, being more willing to see the enrollees for that health plan. And we do oversee the accuracy of provider network directories. We are going to be enforcing 5300, but a lot of that is we need to hear from people when they encounter issues.
Thanks for jumping in there, Jane. I want to take us to another question. Senator Warnick has her hand up. Senator Warnick.
Thank you. And I want to add my appreciation for a very good presentation. My question has to do with a young person, probably teenager or younger, being released from an emergency room or released from care. And I didn't write down which one that was, but did you hear that happening very often? And are there suggestions to avoid a child being released and ending up in a homeless camp and being targeted? Because I've heard this before. And is there a recommendation that you might have after speaking with those folks? How we can prevent a child being released from an emergency room or other care without a parent or a guardian knowing that?
Yeah, so this is something that came up quite a few times in our stories. We kept that one specifically because it was a youth, and we know from the youth panel that there are not enough youth services.
Mm-hmm.
So one of the suggestions would be to increase the amount of youth services available so that there is somewhere for them to send that youth, for them to go after the emergency room.
Mm-hmm.
But one of our insights related to emergency departments that we didn't spend a lot of time on is that people are often feel like they go to an emergency department and then are discharged from that emergency department without any real behavioral health intervention taking place, which is not surprising. We know from a lot of conversations about emergency departments that they are not an ideal location to get behavioral health care. People go there because there's not a lot of options. And like we said, we're hoping the 23-hour centers are a better alternative once those open. So they can get some treatment from somewhere that's more modeled towards behavioral health rather than emergency physical health situations. This also goes into a conversation about natural supports, though. especially with teenagers, there's a lot of conflict between the agency of the youth, because once they turn 13, they have a right to access and use services without consent of their parents, but also that the parents are responsible for this youth, and so they generally want to be involved. They want to know what's happening. And I don't know that we have an answer for that. This is something that's talked about a lot in our subcommittee, because when there's a solid family foundation, they can be a very good natural support for that youth. But we also have to recognize that sometimes a youth's family are not positive natural supports. They are a source of trauma and stress, and that's why the youth doesn't want them involved. I don't know, Bipasha, do you have anything to add there?
I just wanted to reflect a couple things. Joan, you said we need to hear from people if they're running into these, ghost network issues. And also, Senator Warnick, you asked if we talked to these people. So this was a story submission project just by writing or submitting we had initially envisioned this project as a two-step process, which is doing this as the first round, and then being able to actually do the interviewing with the people to go more in depth into what happened. And unfortunately, because, the CRIS process is sort of the way it's being run is ending. And so our request is to see if HCA or whoever takes it on, or and it doesn't have to be under CRIS, but is there a way to provide people to be able to give direct input about their experience to the state? I think that's what's coming up from both what you all said, and how can we follow through? We've tried that through the CRIS's lived experience subcommittee, which has been an amazing opportunity for the community, but just a thought, putting it out there for whoever has the power to figure out how do we keep this going on in perpetuity, not under the CRIS necessarily, but we need a space where people can really give direct feedback to the state on what they're experiencing in the system.
And thank you for that. And I don't mean to say that the emergency rooms are not the place for some of these treatments. I think they do amazing work in most emergency rooms, and they just can't do it all. So we just have to be able to support the people that's the only place they have at this point. So thank you. It was a very good presentation.
Thank you. And I think I just want to, we did mention the 23 hours drop-in groups. As they, expand across the state, they will take that pressure off the emergency department, and people will get more tailored care over there.
Yeah. Very good.
So we have a very short time left. I see hands from Puck and from Dylan, and then we're probably gonna have to go to our break. So let me bring it over to Puck, and then Dylan, I'll come to you after that.
Yeah, I wanted to thank you both for so much work that you put into this, and also just to speak a little to the limitations of this project. This camp came up after we brought several experiences to the CRIS, and we kept hearing responses of like, oh my God, that's so terrible. And the stories that we brought, like as lived experience people, we've heard and seen over and over and over again. So we wanted a chance to highlight the fact that no, these aren't individual terrible experiences. They are happening regularly. And we were able to get a fair bit of feedback by providing some financial compensation for this. So we weren't just asking people to tell us about it because they cared and had hope for the system, but there's still a really huge lack in this, in that basically, like, we're not getting to the people who have been most failed. We're getting only to the people who are still able to advocate for themselves or have people who are caring for them. And without doing some very intentional on the ground work to speak with the folks who are still in crisis, which is almost impossible, this is still a really shiny, good picture that we're seeing here.
I also want to acknowledge that that is a theme that you have brought up to us in many conversations, and I want to honor that you raised that to this committee. I'm going to bring this over to Dylan now.
Hi, thank you. Dylan Ishmael, Philippine Program.
Patient Health and Referral Service. For folks that are from the county, we have a process for the coordination of care, a notification system for providers to talk about the transition of care following hospitalization and other types of care, which it is specific for providers, but I love the lived experience feedback process as well. If there was a way to get multiple angles of the story of what went wrong and what could be done better, and to see any failures in process and protocol, we'll be able to see that as well.
So, Bipasha and Kristen, I'm hearing some echoes of your call to have opportunity to do more in-depth work on this. So, Kristen, do you want to throw something in?
Yeah, like Puck said, we didn't get to do the whole project as we envisioned it. One of our motivations for this project was that we had a person in our lived experience subcommittee describe a situation that happened, and then between us with our lived experience and the different agency staff in the room, we were able to figure out exactly what happened and why it happened by having a conversation, so we could know what the solution was. So we really wanted to have the opportunity to interview these people more in depth after hearing their stories, so we could kind of go through that process on some individual stories and get more detailed information about why their story happened the way it did, not just what happened. And it's hard. It would require a lot of outreach. It would require a lot of work, but we feel very passionately that moment in our subcommittee where we were able to actually state, here is what happened, here is why it happened, here's how we fix it, was only possible because we engaged with a person about their story of their experience in the system.
I'll just add a little more detail. Kristen, I think you're referring to the point where people were transferred 4 times before they talked to someone. And I think between DOH and HCA, we figured out that they had gotten bounced to Vibrant instead of within state. And that was also addressed by that decision, which I love, that in Washington state, if one of the hubs cannot answer the call, it will float to the next hub within Washington state, which is better than it going to this centralized place somewhere on the East Coast where people really don't know the state and the area. So that was what Kristen was referring to, and that was very helpful for both the client and I think for the system.
Michael has one thing to add, and then I want to read a comment that Kashi just sent so that everyone can hear it, and then we're going to go to break.
Yeah, hi all, Michael Anderson, AP, he, him, his pronouns. I had the honor of working with Bipasha and Kristen on this analysis and coding, and I read all the stories. And, you know, this is a ton of work to get distilled down here, but I will say that someone who read every story and all the words, there is so much information in those stories. And you know, we only have like 1 or 2 quotes underneath some of the insights, but there are many quotes, and like one story often touches on many of these insights, right? So there's a lot of richness in these stories. It was very hard to read all these stories, so kudos to Kristen and Bipasha for sticking through it and for putting this together. But there's a lot of rich information if we just listen to those who are accessing services. And I just wanted to lift that.
Thank you, Michael, and I think this is a perfect closing comment for Kashi. Thank you so much for this work. These are incredibly resonant. It is really important and powerful to hear these stories and to be accountable as a system to be doing better. So thank you for that. And I apologize, I should have mentioned this before I went into the discussion. Luckily, I think we all did a pretty good job with it, which is our ASL interpreters are working very hard to keep up with our conversation. And so the more that we can slow down, which is one of my personal challenges, and enunciate, the easier we will make their very hard job. But I think this last discussion went pretty well, so thanks everyone. With that, I just want to give a huge echo to all of the compliments and appreciation that has been shared here for this work that Bipasha and Kristen have done to pull this together. And of course, Michael Anderson and Nathan, tremendous work. I think this has been really informative, and I think we'll really make our discussion this afternoon about our recommendations all the richer. So, oh, and Christine Milana, thank you. Yes, anyone else? No, but Christine. again, Christine did a lot of work too, Christine's on today, so Christine, big thank you to you too. We're gonna take